and to be amongst the doyens in the vitreoretinal surgery. So I'll just start my screen share. Okay. So this was the case which I first started, and initially after any primary failed macular hole after the ILM peel, I go ahead and do what is called, as you can see there is no ILM. So I do what is called as the ILM transplant. So what I do here is I inject a little bit of viscoat in the macular hole, and then I try to peel a little bit of ILM from the temporal aspect and try to stuff it inside the mac hole. But I realized that the hole size was bigger and the flap was too smaller. So the importance here is to get a good single sheet at once. That is very, very important key. Otherwise, every time we have to keep stuffing it. And there is a danger that we might touch the RPE or the choroid. And here you can see I'm just stuffing it up intraopposity, and then you can see there is an excellent closure of the anatomical, and the surprise that the vision improved to 6/9 from 6/60. So this is my another case where I just thought I will do the same thing. This is I did about the macular detachment induction technique, which I'm going to describe, the pre and the post-op. We can see here. So I thought this would work. I had done 4 cases of that, but let us see what happened in this case. So here what I do is use a 42 gauge syringe and try to detach, do a macular detachment induction technique using a 42 gauge syringe, superior temporal and inferior to the fovea, and avoiding the papillomacular bundle. So what's the rationale of this? I followed this technique from one of my mentor, Dr. Curtis, and Dr. Rajiv Muni. He actually published in the Retina. Here, it reduces the tension and the stiffness, which is intrinsic to the retina, and separates the tight adhesion of the retina and the RPE. But we must ensure that the retina RPE adhesion is completely lysed around 360 degrees around the mac hole. You can see here, by doing a fluid air exchange, you can see the bullosity coming on, and we must ensure that there is a 360 degree complete lysis of the attachment. But unfortunately, you can see this. In fact, the hole size went bigger after this technique. And then I went ahead and did a neurosensory graft. Again, I injected a little bit of 42 gauge this thing. With the 42 gauge, I injected some saline and tried to create blisters because I don't want to inadvertently cut the RP or the choroid. And again, you can do it unimanually or bimanually, the various techniques where you can slide it under the PFCL also, whichever suits best in your hand. And then I just applied it over it, and we can see now it's placed over the mac hole. I just did a laser to that. AIOC2021 confirms the exact placement of the hole, the flap, the retinal graft over the hole, and a careful fluid air exchange. And we can see here, there's a good improvement from counting fingers to post-op 6/36. Thank you very much.
Thank you very much, Dr. Joshi. I think that was a very deft sort of handling of the flap, which often gets lost when we are attempting to manipulate it. I would like to bring in Dr. Naresh Babu here. Dr. Babu, are you there?
Yeah, I'm there.
Yeah, good morning. So, Dr. Babu, in case one is handling such grafts, especially in high myopic eyes, where the tendency of the ILM to split off into smaller pieces keeps happening, how would you tackle the ILM graft in these situations?
Actually, one thing is you can fill the eye with the PFCL, and staining under the PFCL gives instantaneous staining. And because of the counter pressure given by the ILM, especially in thin retina like myopic eyes, it's easy to peel, number one. And number two, I think even you have published, there is not much difference in the visual acuity when you're transplanting the ILM in the macular holes. So I'm not really convinced about stuffing the ILM holes with macular hole, because there are 2 publications back to back which says there is not much of improvement. Maybe it can close the hole, but not the vision as such.
Right. So suppose one is attempting to do this maneuver, and when ends up having bleeding right there in the base of the hole, then would that be a matter of concern, or would we look at it as a positive factor, which may in fact help the hole to close?
So depends on which article you have read. If you have read Hina Chakrabarti's article, you'll say it's, oh, I'm going to plug the macular hole with the blood. As she has told in 3 layers, she has plugged the hole with the blood, and she has left it without tamponade also. So if you would have read that article, you are happy. Otherwise, you will evacuate and they will redo the procedure.
Right. Right. Thank you for that.
Dr. Vivek.
Yes, Dr. Joshi.
This question, actually, I had one more case, the reproliferation of the diabetic retinopathy case, where ILM peel was done in the primary surgery. So while peeling the membrane, there was a slight bleeding. Even in spite of putting PFCL, the blood was coming over the macula. And at last, I lost the orientation, because the more the blood we try to pull in, the more enlargement of the macular hole will happen. Then I trusted, then I thought, okay, I thought it is the center of the macular hole, and I just left it. And fortunately, I don't know, the patient had a very good improvement. So I don't know whether to attribute it to the graft or to this thing, or double combo, both together helped him in getting a good anatomical as well as visual outcome.
But again, most of these cases are anecdotal, Dr. Srinivas, right? We'll have to have maybe a trial to say that whether they are really effective.
Yeah. We need a long set of cases to actually prove it.
Dr. Shukla, you would like to come in with a point? Your mic's muted, Dr. Shukla.
Shukla, sir, you are muted.
Am I audible now?
Yeah.
Yes, absolutely.
So there are two things. Srinivas, very good surgery, very skillful surgery, but I would say it's an overkill for two reasons. Actually, first of all, the macular hole you showed are not really large macular holes. The macular holes of 400 microns or more were considered large earlier, but now the Manchester study has shown, as my personal experience also, I'm sure a lot of other panelists also, up to 600 micron macular holes can be easily closed by a rexus which is done up to the arcades actually, and no special procedure required for that. So, doing a graft of a full thickness retina, even doing a flap, and one particular aversion I have is to insertion of the flap into the hole actually. If you layer the flap over the hole as a scaffold, that's an acceptable alternative. That's difficult to do. But if you try to stuff the metal something into the hole, it actually prevents the photoreceptors from approximation. So that's my point. Thank you.